thank you all for being here, and all of you from this morning. I think we certainly threw a whole bunch of issues up in the air this morning, and I expect we're going to continue having them reverberate through the rest of the event. Today, we're going to start right now. We had a view from the trench, one of the views from the trenches already, but a few, as we were organizing this event, there was a terrific podcast on all of our favorite radio show, Radiolab. And it happened to be on this very subject, in some sense, only from the doctor's point of view, and it was put together by Sean Colt, who's going to describe the whole thing.
Indeed. Hello, everybody. I'm a producer, radio producer, and reporter, and a colleague of Jad Abumrad at the end of the table. And so we're going to, I was telling, these are doctors Ken Murray and Joe Gallo, and I would introduce them, but the piece that we're going to play does that necessarily, because you have to do that in radio pieces. We were talking about how many synergies we are hearing from between the stories that aired, this is thinking in radio, stories that...
Everything is radio.
Everything is radio. Stories that were told this morning and the points that are raised in the piece. It's almost, scary how much the same sort of troubling things come up. But this story and the conversation we're going to have approaches it from the doctor's perspective, not the doctor's communication about care to the patient, to another, but the doctor's communication about care to him or herself as the patient, which is interestingly different in ways that you will now hear. So we're going to play this. It's about 20 minutes, and then we're going to free-form go to town. And then there'll be, and obviously want to hear your input and questions. So here is what we put together.
Should I go first? That
Go
always
first.
shocks you.
Yeah,
Okay.
do it.
Hi, I'm Robert Coleridge,
I'm Jad Abumrad.
and this is Radiolab.
The podcast.
And on this podcast, we are going to have a conversation. Not an easy conversation, I wouldn't say.
No. It begins really with a difficult question. Maybe the most difficult question a person can be asked. And asking it for us is our producer, Sean Cole.
Well, this story starts with a doctor, a guy named Joseph Gallo.
Hello?
Can you hear me, Joe?
Yeah,
Okay, great.
yeah.
He's a real sweetheart, actually.
I feel like a celebrity. You're sending a sound person here to record
Joe's an MD, but he's also a professor,
at Johns Hopkins University in Baltimore.
and he's been working on a study that I just frankly find totally fascinating.
Let me, if I ramble, just stop me. But
So here's the story. A long time ago,
in the 1940s and early 50s,
Johns Hopkins launched something called the Precursor study, and all of these graduating medical students
1,337 students
signed up.
between 1948 and 1964.
And every one of them agreed to be poked, prodded, examined up and down,
Their blood pressure, their weight,
asked all these questions.
their habits, how much exercise they took. They did Rorschach ink blot tests.
Wow.
And what was the point of this study?
Well, originally it was just to pinpoint the precursors to heart disease, but over time, the study went way beyond that, and the researchers started asking all sorts of other questions.
Questions about depression, anxiety,
Like 50 years of this study, and the doctors are getting older and older,
social
and
support, retirement.
at a certain point, about 15 years ago, Joe and the other researchers start to ask these doctors about death.
So if you have that paper in front of you,
Yeah, hang on. Essentially what they did was they presented the doctors, many of whom are now in their 60s, 70s, and 80s, with the following scenario.
Scenario is there.
It says, and it goes something like this. So say you have brain damage or some brain disease that can't be cured, you can't recognize people, you can't speak understandably, and you're in this condition for a long time.
Like you're brain dead.
Well, you're not brain dead, but it kind of describes maybe a scenario that's like severe dementia.
And then it says, indicate your wishes regarding the use of each of the following medical procedures.
This is a list, 10. CPR, IV fluids, major surgery.
There's a bunch of them.
So the question they're asking is if I'm in this terrible situation, would I want these things?
Would you agree to have these things done to you if it came down to it?
Right.
Okay.
So what would you say as an example?
You're asking us now?
Yeah. And I also put the question to a bunch of people in the street. Excuse me, sir. My name's Sean Cole. I'm a reporter with...
Well, give me one.
So CPR, for example. So your heart stops CPR.
Would I want CPR?
Yes.
Well, yeah,
Yeah.
I want somebody to do that.
Yeah.
Sure, yeah. Yes.
Well, yes.
Seems like a no-brainer.
What about mechanical ventilation? It's a breathing machine.
A breathing machine.
You're gonna die if you don't get it.
Well,
Maybe.
Then yeah, okay.
Yes.
Yeah.
Sure.
Yeah, I wouldn't say don't do it, yeah.
You remember all of them. Kidney dialysis. Dialysis.
Yeah.
Yes.
Right?
so.
Feeding tube.
Yes.
Yep.
Major surgery.
I don't know.
Like a gallbladder operation.
If we're just talking about the gallbladder.
I'm sure. Yes.
Yeah.
Antibiotics.
Yeah.
Totally.
Sure.
Sure.
IV hydration.
Yes.
Yes.
Obviously.
You would want all that.
Yeah.
Yes, yes, and yes.
So that's what most people say. They want most everything. Maybe not some of the super invasive stuff, but generally, yes.
Okay.
On the other hand, you ask the doctors what they want, same situation. Brain dead or brain injured, whatever. Do they want CPR?
90% say no, they would not want CPR.
Really?
90%?
90%?
No, yeah. I mean, and I asked a bunch of doctors at a vascular health conference here in New York.
Each of the following medical procedures.
And they said the same thing.
CPR.
No CPR.
No.
No CPR.
No CPR.
And almost 90% wouldn't want ventilation
No.
or dialysis.
Definitely not.
No.
80% would not want surgery.
Well, no.
80% would not want invasive testing.
No.
Almost 80% wouldn't want a feeding tube
What?
No.
or blood product.
No.
Antibiotics, 60% say
No, really?
IV hydration, about 60%.
Say no.
And they don't.
Probably not.
And then pain medicine is the one that's a bit different.
The actual item on the survey reads, would you opt for pain medications even if they dull the consciousness and indirectly shorten my life?
There, 80% of them say
Yes. Yes. Yes.
Pain reliever, yes.
Absolutely. Yes. Yeah.
More.
Yeah, painkiller, yes.
Yes.
Pain medication, yes. Yeah.
So pain medication that's all they want?
For the most part, yeah.
Why would there be such a big gap between doctors and patients?
In terms of how they want to end their life?
Yeah.
Well, hi, is that you?
It's me.
Great to meet you.
You also, Sean.
How are you doing? It started to become clear to me when I talked with Ken Murray. He's also a doctor.
And you're in your Dr. Whites here?
I thought I'd impress you.
I met up with him at a hospital in Los Angeles. He's written a bunch of articles now about how doctors want to die.
This exact question was asked.
So I asked him, why is there this difference, particularly with something like CPR? What is it that doctors know that we're not aware of?
Well, we know that CPR is basically pretty terrible as an intervention. It basically doesn't work very well. And people just don't believe that. They just can't believe it.
And for very good reason. There was a study done in 1996 about how many people survive CPR intervention on ER, Chicago Hope, Rescue 911. It's 96. Those are hot shows then. And so the researcher watched all of these medical dramas
And recorded what the result was.
Come on, you can do it. Come back to us, Don. Do it. Come on. 2, 3, 4.
And the answer was 75% of the time, people
Come on. Okay, get the oxygen. Easy breath.
were revived.
Come on, nice. Easy breath. Give it to her. Come on.
It worked 75% of the time.
Easy breath. Easy breath, John.
The actual number is more like 8.
8%?
Roughly 8% survive to at least a month.
And in fact, it's worse than that.
Here's how that 8% breaks down.
When you actually break it down, there was a fellow who did a study in 2010. He looked at 95,000 cases, actually more than that. And I think it was all the cases in Japan that year. And what he found was that about 3% had what you would call a good outcome. That is, return to a meaningful quality of life.
You and me sitting here talking and eating sandwiches.
Exactly. About the same number,
3% or so.
ended up in a chronic vegetative state. Not quite brain dead, but pretty close.
And the final 2%.
Were in some sort of intermediate level. Not good, but they weren't comatose. Everybody else was dead. That's the reality of it. And we physicians, we know that. We've actually done CPR. We have actually laid hands on the chest.
Here's something I didn't know. Ken says that when you do CPR, you often end up cracking the person's ribs.
Wow.
And yet that, according to Ken, is kind of mild in terms of some of the things that doctors put patients through.
I think a lot of times we're doing things to people that we wouldn't do to a terrorist.
Is that true or is that overstated?
I'm not kidding.
Like what kinds of things?
Well, paralyzing somebody so that you cannot move, which you generally have to do when you put a person on a ventilator, a breathing machine, a respirator. When you put somebody on one of these machines, it breathes for you. But the problem is you'll fight it because you'll have your own rhythm. So what happens is you have a person that is fighting, and you can't get air in and out of them. So you paralyze them.
So they stop fighting. You know, they can't move.
But it doesn't mean they're asleep. They're not asleep. They are completely helpless. And yet they're aware of everything that's going on around them.
Sounds nightmarish, actually.
Yeah.
Ken took me through a bunch of different situations, from congestive heart failure to lung disease and pancreatic cancer, where he feels basically that the treatment is like worse than the actual disease of what you have. It may be prolonging, but not for very long, and the life that you have left is misery.
Right.
In fact, Ken says that colleagues of his, other doctors,
They'll turn to me in the ICU and they say, if you find me like this, kill me. And they're not kidding.
he says there are doctors who wear medallions with the words "no code" stamped on them, which just means "don't resuscitate me." He's even seen tattoos that say "no code."
Okay. Can I talk to you now?
Yes.
Do you have any idea? Come on, turn that off. All right, Sean, can I just break in for 1 second?
Yeah.
Because while you were reporting this piece, a very strange coincidence happened to me. I was visiting my dad, and after dinner one night, he sits me down and he says, I have something important I want to tell you. I've signed an advanced directive, which basically means if I end up in the hospital, terminally ill or something, I don't want a lot of medical stuff done to me. I had not told him about your story at all.
Really?
Yeah.
So it was just
Out of the blue.
And he shows you a piece of paper, or
No, not then. But I just saw him a couple days ago and asked him to read it to me because I hadn't actually seen it yet. What does it say?
It says, I direct that medical care be withheld or withdrawn, and that I be permitted to die naturally with only the administration of medications.
You can skip over that paragraph.
I authorize the withholding of artificially provided food, intravenous fluids, and other nourishments.
If I cannot give directions regarding my medical care, I intend that my family and physicians honor this declaration as the final expression of my legal right to refuse medical care, and I accept the consequences of that refusal.
Yeah.
Huh. So pain medication is all you really want.
Yeah. To keep me comfortable.
So, looks like the baby's crying. So it sounds like, why wouldn't you want artificially provided food, intravenous fluids, or other nourishment?
That's my choice.
I know, but that doesn't sound like it's that much of an intervention, really.
It is an intervention to sustain life unnecessarily. If I should ever have a terminal condition.
Would you want CPR done?
If I have a choice, the answer is no.
But wouldn't you want Mom or I to be in a position where we could make the decision?
I mean, what if you conflict?
Like she feels one way, I feel another?
Yeah.
He told me this is one of the worries that doctors have, that they'll have talked to the patient or the patient's family, explain the situation carefully, and everyone's agreed, no more interventions. But then a random family member will just show up, like a cousin or an estranged son or daughter, maybe carrying a lot of guilt. And they're like, no, doc, you have to do whatever it takes.
At the end of the day, I give the option to the patient and to the family to make a decision. That's what I have to do.
Except in this case, when the patient is him. But by having this, it means we have to honor this, right? We can't have our own feelings about it.
You can have your own feelings, but you still have to honor this.
But it's just the thing that gives me pause is that, I mean, you're a doctor. Your job is to prolong life and to sustain life, and you choose not to when it comes to your own life.
Nobody said my job is to sustain life. My job is to sustain life when it is possible. It is not to sustain life when it's futile. And if you're going to sustain my life on a respirator, I don't want it. That kind of life, I do not want.
More than anything, the thing he wanted to make sure of is that he does not die in a hospital. He definitely does not want to die at the place where he works.
That's something that came up a few times among the doctors at the conference that I went to.
I think I don't want to die in a hospital bed.
This is Tim Ryan, a resident at Cleveland Clinic.
Why not?
Because I see patients and patients' families suffer tremendously, and I think we do a poor job of communicating futility to them. I don't know how to communicate that effectively. I don't know how to do it better. It's a difficult thing to bring up to the family. How do you tell them your grandfather is not going to get better? We can keep him alive for a few weeks or a few months, but he's probably going to have a tracheostomy and a feeding tube, a catheter in his bladder, and then he'll get bed sores and slowly deteriorate. I think we can focus on, extending a life that has some quality so they can interact with their family, but once that's gone, I don't know that we do much benefit.
It sounded great. That was perfect. Why didn't you say that?
I don't know. You have to have a sense that people want to hear that.
Well, no one would want to hear that, but they would need to hear it.
But it's a little bit presumptuous.
You can't tell someone not to hope. You can't pressure them to just let go of their loved one. And obviously you can't refuse to provide care.
There is one thing that struck me that talking to my dad. There's a question that patients will sometimes ask that can be a kind of bridge between doctors and patients. Very often, he says, when people are in the middle of this decision, they'll turn to him and they'll say, Doc, what would you do if this was your mother or father? And he says when they ask the question that way, it creates an entirely different conversation. He can say, here's what I would honestly do. Or in fact, and I did not know this, here's what I actually did.
It happened with my parents. When my father fell and developed complications as a result of the fall.
He says he called the doctor and told him no more medical interventions.
And he ended up dying comfortably. Same thing happened with my mother. I had discussed it with my mother and my father when they were not sick. This was a plan. I can tell you in 9% of the patients that I see, such planning doesn't happen.
I had a habit for most of my career when I'd have a new patient come in, particularly over the age of 50, I'd ask them, how do you want to die?
This is Ken Murray again.
A lot of them, you give me kind of a funny look. That's an odd question for a doctor to be asking me. And I said, well, it's the one thing we can be sure of that's going to happen eventually, and I want to make sure it happens the way you want. And so people, the typical answer is, well, I'd like to die in my sleep, painlessly.
The fastest way without any pain.
Peaceful. Without pain and with friends.
Which is how most people answer the question.
Doctors and non-doctors.
With the least amount of pain and not drag it on.
Swiftly and painlessly.
But what is that? I mean, what actually is that? That's usually a heart attack or stroke, something of that nature, that happens just like that, and you're gone.
And that's what we and our doctors are essentially doing everything in our power to avoid. So, like, when you ask people in the abstract, They're saying,
how do I want to die? Peacefully.
I want to die peacefully, I want to die in my sleep, and everything like that. But when you ask them the specifics, you hear,
no,
pound on my chest, stick a tube down my throat. So it's this paradox.
Well, it sounds to you like a paradox, but think about it. It could be, it's so healthy to do both, even at the same time. It's healthy to want to stay, and it's healthy to know how to be ready to go. I was listening to a Fresh Air sort of retake, and they had Maurice Sendak on the air, who died not too long ago. Before he died, he was on Fresh Air.
It's an amazing interview.
Yeah, and
It
Terry
really
Gross was talking to him, and he's sitting there in his Connecticut house looking out the window at a tree. And he says to Terry, I am so in love with the tree and the beauty of it and my chance to keep it company just a little while longer. And I want to stay. And every extra day I get is a day that's precious to me and makes me want to stay even harder. But he says to Terry, I am ready to go when it's time. I've made myself ready.
Mm-hmm.
And that compromise you make with yourself, to love it with your whole soul, and yet at the same time say, I'll know when it's over, and I'm composed enough and prepared enough to take my exit. That's what a good death is.
That's it. Thank you. So, I mean, obviously a lot of issues are raised, and we can get into them. I just want to start by saying there's a difference always between radio and reality and the way that things happen and the order in which you find out certain things. And like, we wanted to start with the study because A, it is so fascinating, and B, it put a sort of order on the thoughts early on in an important way. But the story actually came out of Ken's article that he wrote for an online sort of community called Zocalo, where I saw it, and it said, in fact, a listener posted a link to it on Radiolab's website vis-a-vis what he says in the article about CPR, because we had done a piece about the CPR dole. And I read this, and I was like, wow, this is amazing, and I'm sort of handing it around to the other producers, to Jad at the show, and they're all kind of skeptical as to whether it's true. Is this a thing? And then so I called up Ken and said, is this a thing? And he said, you wouldn't believe how much of a thing this is. So I just wanted to, because we didn't get to this in the story, talk about why you decided to write about this in the first place, or how that happened and what the response was to that initial story.
Well, first, thanks for inviting me to this conference, and I want to especially thank Joe Gallo, who I've been making a living off his research for the last year and a half. But
can everybody hear?
What occurred was I had simply noticed myself. I'm of an age where my colleagues are dying. We just reached the age where you start to have some mortality. And I had just noticed over a period of time that none of them died in the hospital. And I just thought one day, and I can't remember which specific doctor it was, had passed away, and it made me start to think about it. And so I started to talk around the lunch table with some of my colleagues. I says, I don't remember anybody dying in the hospital. I said, you're right. And I thought, well, yeah, I'll bet this would make an interesting story. And so what happened was I was approached to write an article on end-of-life issues. And so I said, well, sure, I can write about that, but I think I've got an interesting twist on it. And so I went ahead and pitched the idea. And the editor's response was exactly what yours was, is that really true? And I said, yeah, it is. And so we went ahead and wrote it, and it was published.
And what? And then what? And then talk about how what happened out in the world after people read it.
A tsunami broke over me. I mean, I thought it was a nice article, but the reaction to it was absolutely astonishing. And I mean it in the context that it was a reaction far in excess of the quality of the writing, I assure you. But cited on 30,000 websites, translated into every language that I've been able to check it on, Swahili, and cited in newspapers all over the world. I've been interviewed by the major newspaper in Beijing, in Brazil. I've been interviewed on Irish Public Radio twice. And there's just been this astonishing interest in the topic of end-of-life care, particularly in the way I wrote about it, that doctors make a different choice. And I remain perplexed over the response, and I think it's a series of things that just came together at the right time, and I just happened to write the paper at the right moment for people to latch on to it, because I can't otherwise explain it.
And what I thought was interesting too is after the Zocalo piece, many of the comments online were from doctors saying yes, it's true, and supporting it, and also, patients with their own stories, and then one or two other doctors or people, whoever they were like, well, this is good and all, but do you have any statistics to back? Do you have any numbers? And you did have numbers.
Yeah, it was interesting. There were two items in which there was pushback. The first was on the CPR issue. People just don't believe it, that it's not miraculous and works all the time. And the second part was, well, that's your opinion, but have you got any proof? And in fact, there is a significant amount of literature that addresses that, and I wrote a follow-up piece for the Wall Street Journal in which I cited those things, including Joe Gallo's work. And once again, you mentioned the comments on the original Zocalo piece. There were 700 comments to the piece. On the Wall Street Journal, I think it's around 600 right now, including hundreds of doctors and hundreds of other healthcare workers. I mean, there's a lot of resonance on this subject.
Yeah, and lots of comments too on our site. Were you going to? So Joe's work, I got through the article actually, and it was probably the Wall Street Journal version where you cited his numbers and called Joe. And Precursors, definitely read more about it, because there's a ton that we didn't get to talk about related to this issue and not with the Precursor study, including that, in the main, as we said, and you should look at this bar graph where it's talking about the intervention and sort of yes or no, or no answer, and it just looks like a series of skyscrapers where the no is in black, and it's just like straight across and then dipping down with some of the less invasive interventions. But there are people who say, yes, I want that. Yeah, doctors. Yes, I want this intervention. Yeah, yes, I want everything. Or yes, I want, some of the more invasive things. And that's...
Yeah, well, one question I have is, how do I get an editorial in the Wall Street Journal? No, I'm really gratified to be here. And Nancy and Heather, I don't know you, but I really admire you for the courage to get up and talk about the experiences, that you had. It reminded me of experiences with my own parents, one where my father, who was born in 1904 on 125th Street, actually, in New York, hated doctors. He did not want... In fact...
What did he think of you in that case?
He discouraged me from... He would say, medical school, that's too hard. You don't want to do that. He only had about a second or third grade education. But I will say, with the family rallying around, we were able to keep him at home. He did die at home. The idea of being in an intensive care unit in the hospital, I mean, that would have been the most awful thing that could have happened to him. Not to get into the personal, but I didn't mean to say this, but then my mother, I remember as a medical student, she coded during dialysis. She was diabetic, but I remember the conversation with the cardiologist. One word he said, really, it's just amazing how the words people say could really make a difference. One word I remember, problematic. He said, your mother's recovery is problematic. And I remember thinking, wow, here's a time to minister to the family. There's nothing more that he's going to do. And it just seemed like such an odd word, to say. But Precursors really was ahead of its time. It was founded by Carolyn Bedell Thomas in 1946 and consists of all the medical students between 1948 and 1964. And she called them precursors, what today we think of as risk factors. It was really a study about risk factors, blood pressure, et cetera, in early life, and what would happen in midlife. It's just that over time, it's become a study of aging. And at the end of the 1990s, I was asked, I had about a 10-year extended sabbatical, you could say, at the University of Pennsylvania, but always stayed in touch with the project. And they asked me, well, what's an interesting aging idea that we could talk about? And I said, well, maybe you should ask them what they would want for themselves at the end of life. And so we've developed a data set, which really hasn't been fully explored, looking at what their preferences are in relation to this scenario. And a scenario like that, those weren't questions that I made up. That was from the medical directive that had been published basically 4 or 5 years earlier. This is 1998 or so, with these different scenarios. And frankly, we just thought that was the most controversial one.
Right, that it would lead to the most varied responses.
Yeah, I mean, whether
that's an important
would
point.
have or not, I don't know. But so the article that Sean's talking about, we looked at basically what did they say that they would want in response to that scenario, and some other things about what fraction of them have a living will or durable power of attorney, et cetera, whether they think their spouse knows what they would want, et cetera. But then we started looking, one thing the scenario allows you to do is maybe you can say something about responses over time. They're doctors, right? You don't have to explain what CPR is to them. Presumably, if it changes, it's because something about their physical or mental health has changed, or their age, or other factors. And so we started looking at, over a period of 3 years, 6 years, what happens to those preferences to that scenario. And it turns out we used a mathematical model that lets you sort of, rather than just considering CPR by itself, but you think of them as sort of like packages. And so there's this small group that seems to say they want these procedures, but it's not stable. So if you start at the beginning with that group, which is about 5 or 10%, very consistent with what Dr. Meyer said about the rest of the population, then 3 years later, 6 years later, only about 40% of them are still in that category. And in the 60% who said they didn't want anything given that scenario, 80% of them are still in the least category later. And that's been found in many, many studies.
Wait, Jeff, I'm sorry. Can you say that again? So there's a small group, and 40% of that group is what now?
So the group that is a small group that's in if they're in that group, they have like a 90% chance of wanting most of the interventions we asked about. So we call that like sort of a more aggressive category. But then when you take them and you look, 3 years later, 6 years later, only 40% of them are still in that category. They still are responding the same way.
Saying want everything.
Right. Whereas the group that doesn't want anything, most of them are still in that same category
stay put.
later, that's been shown in other studies.
This is so funny. This is exactly what happened in the interview in the studio where I was like, oh yeah, and Jad's like, wait a second, could you repeat it?
Yeah. So, no. Was not in the, not in the interview. I worked with a colleague, terrific Marie Nolan, in the nursing school, and she's been interested in not what decisions people make, but how they want the decisions to be made. And she's asked terminally ill cancer patients, how would you, among other things, how would you balance your family and your doctor's decision making? How would you want them? Would you want your family equally weighted or your doctor? So, and what it turns out is in that group of people, about 50% say, I want it mostly to be my family. About 20% say, I want it mostly to be my doctor. But what I think is interesting, or from the point of view of the precursors, because they're all physicians, they have exactly the same distribution. So when you look at their so just because they're doctors, they're not
aliens.
They're not looking different than than patients, because that's been one of the pleasures of being, honor of being here is, like, who cares what doctors think?
That's what you asked us, actually, in the interview. I don't understand.
Unless except for other doctors.
No, because doctors, they're behind the veil. They know what this stuff means. So we should all care what doctors think.
Well, there's one more angle on it, which we haven't done, which is try to look at. So one thing we've proposed is to do, I'll call them ethnographic. It may not be actually correct, but sort of. They say there's three kinds of people in the world, right? Those that can count and those that can't. And so, we have these statistical models, but what we proposed was to use that modeling and try to get a better handle on what's the thinking so, if we pick the group who made that, who look like they're transitioning to wanting more or wanting less, and actually talk to them besides trying to model with the data that we have, and also talk to family members. So the thinking is, I'll run the reasoning by you and see if it makes sense, which is, if doctors can't control what happens to them, then that means that you have to have a different kind of intervention that's not just relying on the individual level, I guess. On the other hand, if they are able to control what happens to them, then maybe it would be important to figure out what are those decision processes so that you can figure out how to
build that bridge,
replicate it with other people. So that's I'll stop.
Go ahead.
I'm sorry.
I can ramble. I actually did ramble, but they didn't put everything in the.
That's the thing, right? We only had 20 minutes.
Yeah, Joe, can I ask you a question? So there's a sense for me that there's what you say you're going to do, and then there's what you do. So do you find over time that some of the people in the no group, this majority, as they get closer to the end, they become yeses? Does that happen?
Well, we have looked in different ways, and we in some of the data, it does look like, let's say, as someone's getting functionally impaired, they transition to wanting more. Older transitions to wanting more. That's what you're.
That's what I'm asking. Yeah.
Yeah. Well, and that's actually, I think that's been shown in other studies, and I guess the thinking is, well, you think, gee, I would never want to be in a wheelchair. I couldn't live like that. But then when it actually happens, maybe it's not. You're like Sendak. You can enjoy the tree. Yeah. So people's attitudes and thinking changes.
How many doctors, from your research, have advanced directives like Jad's dad?
Yeah, so I lost the bet in 1998 because I thought it would be like 10% or something. I'm not sure exactly what the rate is in the population. It's pretty low. 20%. But I lost the bet because somebody said, oh, it'll be much higher. So for these doctors, they're reporting about 50 or 60% of them have we asked about living will or durable power of attorney, but it's very much overlap. They pretty much have both. I'm not sure if maybe it's, this group, it's that, are they really thinking about it and want to plan ahead, or is it just part of like estate planning maybe? I'm not really sure. It does seem to relate to the preferences, because doctors who have a living will or a durable power of attorney are more likely to make a transition in these models going to less aggressive treatment. And when you look at it cross-sectionally, they're
Sure.
less likely to want
That makes a lot of
treatment.
sense.
Yeah, so it's as if they're using it to make sure they don't get treatment. basically.
I thought it would be even higher than 50 or 60, actually.
Yeah.
Were you surprised, Jad, when your dad? Because we heard a sort of recapitulation of the first of what had been a previous conversation, which was it surprising to you, and how did it actually sort of pan out inside your shirt, if you know what I mean?
In my head, you mean?
Yeah, in your.
It was a little surprising. I mean, like a lot of sons, very close with my dad, but we have trouble talking, and so it was surprising to me. Here, I'll tell you. Here's what was surprising. Initially, first of all, just the coincidence of it was surprising, and I was surprised that my own sort of vulturous radio instincts were like, "Oh, I can put this on the radio."
Well, yeah, and you're his kid. You should have seen the vulturedom on my behalf. I was just like, I kept checking, like, have you talked to him yet? Have you talked to him yet? Like,
so there was
Sean,
that.
this isn't the
That's
easiest
sort of-
conversation.
Yeah, he gave me a flat out no on that, but I can I accurately represent him. So initially when we were having the conversation, there was a part of me initially that thought, geez, I actually wish this were a conversation. I wish it were a conversation and not a directive, where we could talk about what he wanted. And then when we got into the conversation and we started talking about dialysis and various things, I realized I so don't want to have this conversation. This is the most awkward conversation I could possibly have with my dad. And then I became very grateful that he actually had directed it so that we didn't have to have that
So
conversation.
you're off the hook in a way.
Yeah, and I realized in sort of somewhere in the middle of the conversation, and you guys should know, I mean, that was like a 3-hour conversation, and I chose only the least awkward moments because it was the most awkward conversation. So like those 40 seconds was culled from just huge swaths of awkwardness. I began to realize that it was a great gift that he'd given my mother and I, and that we now know what he wants. And he's a guy who has always had a very kind of, and maybe doctors are this way dispositionally, very kind of take charge personality. He's always the guy I call when anything is wrong, and so I admired that about him, and I always found it also frustrating. But in this case, I was so grateful that he had taken charge of even this, how he chooses to die. And we haven't talked about it since. And in a way, I'm glad that we don't have to.
Right. I was going to say, and this is something we chose finally the ending of what Robert said about the Maurice Sendak interview, but I think that was one of. We were in that studio for like 3 hours trying to conversate our way to the ending, and one of the things that Jed and I talked about, both sort of off the cuff and also as a possible thing to say at the end, was that sort of commiserating about this conversation having with our parents, because I, in working on the story, went to my folks. I was like, oh crap, like they're in their 80s. I should probably have the conversation now before we're in the thick of a situation that makes it so it can't be a conversation. It makes it more difficult. And I'm like inching my way toward things, and I finally say, because they said, well, we both have wills, and I was like, yeah, I know, but that's after you're dead. This is before you're dead. It's in between the time that you can walk around, be happy eating sandwiches, and dead. This is what we're talking about. Hopefully that'll be 5 seconds. So I finally say, do you want any extraordinary measures done? If you're incapacitated, they were like, nope, just unplug it, turn it off, whatever. And I was like, okay, stop the conversation. I was
That
like,
was it?
I
That
am
was
the
just one-
yes. And I was like, I am the worst reporter in the world? Like, just no follow-up. Just like, oh, okay. That's all I need to know.
Well, one thing I want to bring out of context is I think for physicians particularly who practice, who have patients who die, they have these conversations, particularly with their spouse, all the time. Because these things, particularly when things don't go well, are very bothersome. They're really one of the curses of practicing medicine. So the spouse in particular probably just gets tired of these conversations, you won't believe what happened today, type of thing. And when you understand that things like advanced directives and pulse and MOLS, these are substitutes for the conversation. If you have had the conversation properly, you don't need that stuff to a degree. And I think most physicians would take the position that they can't imagine their spouse or family not doing exactly what it was that they have ordered them to do. And I'm sure they think of it exactly that way. So that's a big difference.
But don't you need it anyway to like be able to shake and say, no, look, doc, yeah, it's a binding document?
I think well, it gets complex. It's always better to have things in writing. And it's one of the scenarios that people have talked about, these pulse or most forms, a physician's order for life-sustaining treatment. This came out of the situation where you have an advanced directive, says you don't want any of this stuff, and you fall, and the person can't get you up. So what do? They call 911. And in the meantime, your heart stops. And you didn't want anything done. But the paramedics, they work under doctor's orders. They can't make a choice. They can't interpret an advanced directive. So what's going to happen is they're going to do everything. So a physician's order for life-sustaining treatment is a legal physician's order that they can follow that says, you will not do this. You will not do these things. And there it is, and we encourage people to put it on your refrigerator. And it's bright pink, as somebody said, so it's really easy to spot, and they're looking for it. So they go to the refrigerator to see if it's there.
And they reach in and have a yogurt.
And so
my job here is done.
So that allows them to stop. That allows them to stop.
For what it's worth, in the precursors, half of the doctors say they think their doctor knows what they would want.
Mm-hmm.
But about, I forget the number exactly, but like 80% think their spouse knows what it is.
Which is more important?
Well, it gets to this issue that you're saying.
Yeah.
That they're communicating something to somebody.
Do you have a sense of one thing and then we'll go to questions, heard, so that conference where I'm walking around with a microphone was the VEITH Vascular Health Conference, VEITH Conference on Vascular Health or something here in New York. And one of the doctors, a younger guy, youngish, told me, I was like, because having read in Precursors, one of the questions is, does your doctor know what you want?
Yeah.
I said to him, does your doctor know what you want? He said, I don't have a doctor. He said, I am my doctor. He said, if I need an x-ray, I go down, I know the guy in radiology, I go down and do it. If I need an IV, I put it in myself, he said. Is that, do you find that a lot of doctors are their own doctors? And Jad, I wonder if your dad is his own doctor, and is it that different depending on the age of the doctor?
I don't know the number. Someone unrelated to the end of life, someone was working on having a usual doctor and use of preventive services in precursors. I don't remember the exact, but there is a substantial number of them, maybe it's a quarter or a third, who say they don't have a usual source of care. They don't have a doctor, basically. And maybe that's surprising. You think that? Is that surprising?
When I said to the dude, was you're a doctor? Of course you have a doctor. But then he's like, no, I'm a doctor. Of course I don't have a doctor. Do you both have doctors? You both have doctors.
I have a doctor of convenience to write prescription, but for example, I administer my own immunizations to myself.
Jad, does your dad have a doctor?
I'm falling into the bad reporter camp. Here, Sean. I have no idea if he has. I can't imagine that he does.
Yeah. Well, let's. We have.
I'm not good enough a doctor to be my own doctor. No, I have my own doctor.
Uh-huh.
And I like having my own doctor. Yeah.
And do you like your doctor, or do you think he's a schmuck? No, you like him.
It's a she.
She.
And she's not a schmuck.
She is not a schmuck. For the record, Joe Gallo's doctor is a woman and not a schmuck. Any 10 minutes? Okay. Who wants to say a thing? And there's a microphone going around? There's a microphone going around. All the way in the back with the sunglasses. Oh, working hard, okay.
In regards to you're interviewing your patients and you ask them about dying, and I would think that the whole conversation has to do with one's willingness to deal with that subject and entertain that subject. Do you find, what is your feeling about people's willingness to talk about death, and do you find that it's dependent upon their age or their sex in terms of their willingness to have that conversation without even dealing with the particulars?
Oh, I found it extremely easy. It was my habit. Definitely everybody who walked in the door over the age 50, I held that conversation. I asked that question on their first visit. And
you're saying that you're kind of provocative about it intentionally. Like
I'm definitely provocative because I'm trying to get a reaction so we can actually have a conversation. People would be surprised by my asking that question, and they'd ask, well, why would you ask something like that? And I said, well, I'm going to be the one who is ordering what's done to you, and I want to do what you want. And how can I do that if I don't ask you? And in fact, I cannot think of an exception in my career where patients were not universally grateful for me asking that question.
All ages, all genders.
Everybody.
Well, all genders.
Everybody was happy I asked them.
Yes, you. You have a mic coming.
Everything in our culture encourages us to grasp for life. Our religions and all other dimensions of our culture. Unlike Eastern culture, where we're encouraged to detach from things, including a craving for life. What I worry about in this issue are two things. The first is that I want to become a cash cow for the medical industry. And at the end of life, you could see these vultures going at you. They know how to charge to the maximum of Medicare and your private insurance. And I worry about that, because if you don't have other people to say no, and you're not able to say no yourself, then they've got you. The second thing that I worry about, and this is a personal with me, is that I'm no longer a kid. I'm really on the downslope. And
you look great.
Yeah. And I don't want to get to the point where you're discussing. I don't want to get to the point where I have a stroke, where I'm no longer capable of dealing with it. And so I think, a time is going to come when I'm going to feel that the end is close enough, and I want to end it. And there's no way to do that. A fellow over here was talking about assisted suicide. They treat dogs and cats with greater humanity. Why not just put people to sleep? Even if your kids want to off the parents to get the dough, what's wrong with that? I worry about that. In my own case, I think, well, I'll get into my kayak and I'll paddle under the Verrazano Bridge, and I'll, end up in the Gulf Stream and return to the land of my ancestors or something. But I really think about that. But the problem is, when? I don't want it to reach the point where I have the stroke. I want to do it 10 minutes before that. But there's no way of knowing, and I can't go anywhere to say, listen, when it gets too bad, just give me a needle and, put me in the mulch pile. That I think is a real dilemma. The costs are extraordinary. I know a guy yesterday. I was just visited a guy. He had a heart reconditioning operation, new valves, new tubes, like reconditioning a carburetor, and he's 85 years old.
Yeah.
That operation and the rehabilitation afterward and all of that must have cost between $75,000 and $100,000.
Let's throw it back to these guys here. What do you?
Well, I want to address this issue of what we call physician-assisted suicide, which I personally don't have a problem with because I'm a arch defender of personal rights, your ability to decide for yourself what happens to you. So that's where I come from. But we don't have to speculate because we've had a couple of states now that have had this option available. I think in Oregon it's been 17 years. And what is astonishing is how few people avail themselves of it. I think the average is something around 40 people a year in the entire state. It's astonishingly small. And I'm not entirely sure why that is, although there's been stuff written about it. Quite a few more people opt for the option but don't follow through. But I think part of it is I think it's actually caused the medical care to be better, particularly what we call palliative care, treating the symptoms, pain, nausea, those kinds of things. Because you can imagine what it would be like as a physician, where your patients would rather kill themselves than have you take care of them.
Yeah.
So, I mean, it's kind of professionally embarrassing. And so
Must be a really bad doctor.
I like to think that, people say, well, if they're in pain, let's do something about the pain. But that's speculation on my part. But that's what's happened when we've made the option available, is the rate that people use it is almost vanishingly small.
Let's take two more. There was one. Jack, can you run over there? This, for those who weren't here before, Ren was like, Jack, I want you to run.
Just two quick comments. One, I just got CPR certified like 2 weeks ago.
Really?
Yeah.
Everybody
So-
pay attention to this.
No, all I'm going to say is, even if it is 8%, it's 8%. It's better than standing there. That's the only thing. When something's going on, that's all I felt like.
This is what I asked Ken. I said,
mean, I agree. They told us, and they were really honest. They go, you think somebody's going to jump up because you saw it on TV. It's not going to be that way.
Right.
Most likely, you're just taking care of somebody till
It's the
an
best we
ambulance.
have.
You're just a layman first responder. That's what I learned. But I learned not enough, but something.
Right.
So that's one thing. And the other thing is, I'm just predicting that suicide will be on the rise once the baby boom generation, it's going to be rampant. And I think everything I'm reading is, my mother has Alzheimer's. She has 2 kinds of Alzheimer's. I'm watching what that's like. And I think that baby boomers and people who've watched their parents care what that is like, it's going to be I think there's going to be a lot more assisted suicide. I think and it may or may not be at all with doctors. I think I'm already seeing there's website exit, I think it's, exit plan. There's it's already, the instructions are already, I learned how. I learned both in the same 2 weeks.
That was in your CPR class?
No, that's personal interest. It is I'm just a very curious person.
Well, something for you to be aware of is the 8% is not for the group we're talking about, people who have terminal illnesses, end-of-life type scenario. That's the statistics for all comers. The statistics for people with end-of-life are much worse. And so there was a great study where they took a group of people who had advanced directives who did not want CPR, and they got it anyway. People panicked, they called 911, whatever. And about 11% actually, their hearts started up again. The problem was everybody was dead in 48 hours. 100% fatality rate at 48 hours. Because you're talking about people whose systems are debilitated and degenerated.
Okay, that's a different statistic.
Yeah, so it's a real different situation in that group of people.
You had your hand up for a long time over here. Way in the back, sorry. Yes, you, behind the man with the red hat. I can't describe you any other way because your shirt is a color that does not exist. Oh, blue, bluish. Okay. There you go. Exactly, run.
So I want to make a couple comments about the issue of, quote, assisted suicide. I'm the executive director of Compassion and Choices of New York, which is an organization that works on this issue and has been for decades. And the comments I want to make, first of all, it should not be characterized as a suicide. When someone obtains lethal medicines, which they can or take if they decide to or not take, when they are terminally ill and mentally competent, it is a much different situation than your typical suicide. Suicides usually occur when people can live. People who are terminally ill are going to die. It's only a question as to the manner of their deaths. It's not a question of whether or not they're going to die. There's a significant difference. These people are not depressed. They have family support. In Oregon, 90% are actually enrolled in hospice. So they're getting the best quality care at the end of their lives. And the studies have shown that there are no vulnerable populations. The laws have worked in Oregon and Washington just as intended, even though, as you said, Dr. Murray, it's used by a very small number of people, which is a good thing, because life for a lot of people becomes more precious at the very end. People who thought they might want to end their lives sooner decide not to. But it gives great comfort to thousands of people who don't take advantage of the law to know that they have this option, this insurance policy. And although Dr. Meyer and I agree on many things, we work together on a number of issues, I would like to see her become a supporter. I know her understand her concerns, but there is no evidence of coercion, which an issue that she raised in Oregon and Washington over the now 19 years of experience in both of those states. So these are laws that have worked in Oregon and Washington. Now the law in Montana and Vermont just passed a law. It was just signed into law about 2 weeks ago. New Jersey is considering a law. Other states in the Northeast are also considering laws. And my organization, if people want to get help, we can provide the counseling and services which frankly are needed for people. You don't have to go to Montana or Oregon, as this woman next to me suggested. You can come to an organization such as Compassion and Choices of New York to get the counseling and services and information that you actually need. And there are other options which are also available, which have not been really discussed today for people at the end of their lives, including voluntarily stopping eating and drinking, and people often don't have much of an appetite at the end of their lives in any event, and also palliative sedation when people have symptoms which are so severe and cannot be controlled by any other means. It's an appropriate thing to sedate someone to unconsciousness, and then they usually die within 10 to 14 days thereafter, and it's a peaceful, dignified way of dying. And both those options are underutilized, but there are a whole range of ways in which people can decide to end their lives if that's their choice.
There's an assumption also that I want to correct, where we lay out a choice of doing everything versus withdrawing everything, or doing palliative care or hospice care. And that has turned out to be a misnomer. There's now developing quite a large body of literature in various medical conditions that shows that when you put people on palliative care, sometimes on hospice care, they on the average live longer than if you have them on active treatment.
And they're more comfortable.
They're definitely more
Yeah.
comfortable because that's your orientation. But
Right.
I think it's not always appreciated how much it takes out of a person to be in pain, to be recovering from surgery, to be taking poisonous chemotherapy. And so removing those things can really be an enhancement of what people experience, and they can actually live longer.
I think that's it. Thank you, everybody, so much for listening. And thanks, doctors and Jad.
Thank you, Radiolab. And we'll take a 5-minute break, and we're going to have the ice flow lady here in a second, Ed.